and our speaker in the IDOH and Limelight Analytics will be presenting today. Yeah.
Great. Thank you, Shalise. Everybody can hear me okay? Okay, excellent. Well, it's good to see some familiar faces and names, but also some new names. We are very excited to be able to share our first report around food as medicine. And this is specific to the produce prescription pilot program, which did happen a few years ago. But we will obviously go over some information and noteworthy things on, maybe that question of why now and those sort of limitations that we had seen. But what we're most excited about is the impact that we did see in these pilot programs and also the evolution of the produce prescription work that's been happening across the state so far. So my name is Michelle Shippey, and I am actually currently in a role as the executive director with the Healthy Hoosiers Foundation. However, I am still sitting in an interim type position as the Food as Medicine Director in the Division of Nutrition and Physical Activity. So I've been in the new role for about 8 weeks, maybe 9. But I'm still here as a thought partner around food as medicine, also the point of contact when it comes to programs. So feel free to continue to reach out as needed. And for anything, I will continue to be, in this space, assisting IDOH where I can, even in my new role. So it's exciting to be able to continue that on. All right. So first here, go ahead and advance the slides. I first want to start by mentioning IDOH's mission and vision. Our mission is to promote, protect, and improve the health and safety of all Hoosiers. And our vision is every Hoosier reaches optimal health, regardless of where they live, learn, work, or play. All right, so many of you on this call are operating produce prescription programs, but I did want to kind of set the stage a little bit by providing a definition that we like to reference when talking about produce prescription programs. So this definition actually comes from the National Produce Prescription Collaborative, and IDOH and the Division of Nutrition and Physical Activity is a member of the National Produce Prescription Collaborative. And to give you a little bit insight of what they do, they are a collaborative. It was created through Wholesome Wave, a national organization, and it was created to help advocate and really push policy around produce prescription programs at the federal level, but also they bring stakeholders together to discuss state level policies, which really helps IDOH stay informed of the work that's happening so that we can then relay that information and work on a state level, activities that could move the needle around this work here in Indiana. But I'm not going to read it out loud, but here is the definition. This is the image. They do have an updated image, but it's very similar to this. And I really like this image about the flow of a produce prescription program and how you're creating them. And one of the things that we've always emphasized when creating a produce prescription program or even evolving it, as one cohort happens or one round happens, we see things that may need to be changed or adjusted. This cycle and this process kind of provides some really good guidance on how we can make those changes. So a bit of background about the start of the pilot programs, and also just wanted to highlight this beautiful picture of Faith Farms in Gary, Indiana. I was up there about 1.5 years ago after a conference and was able to snap some pictures there with Miss Frida. But IDOH received funding from the Centers for Disease Control and Prevention in 2021, and this was part of the CDC Health Disparities Grant. Um, DMPA then received a portion of this funding. I want to say it might have been around like $2 million. Um, and then that funding was then divided up for various interventions and projects within DMPA. On the food as medicine and nutrition side of things, produce prescription was provided a certain chunk of that funding, and then Double Up Indiana was provided a specific chunk of that funding. But then there was a release of a request for proposal, and then funding was granted. And a lot of the projects and programs started in 2022 and 20. I have no idea why it's advancing automatically like this. Okay. And so there were 11 grantees total that were awarded in those 2 years. I did want to just bring some noteworthy and important things to keep in mind as we talk about this report and as Danielle goes into the methodology and results. Um, these limitations and noteworthy items really just provides a great opportunity for us to improve future reports, and also for program implementers across the state, and how you can contribute and continue to contribute to like the data. And so some of these were also a little bit out of IDOH's control, like the very last one when funding abruptly stopped in March of this year. Um, that was something that happened that was very unfortunate. For me, it was a difficult conversation to have to reach out to grantees and say, hey, you have to submit everything you've done up until this far by this date, because this funding is completely ending. And that not only impacted our division, it also impacted the entire IDOH, and many other very, very important interventions and initiatives that were happening. But this funding did emphasize COVID-19 recovery. It Prior to me, there was a process of getting approval from CDC for using these funds as a voucher process. Traditionally, CDC doesn't allow coverage of food. But in this particular case, there was an exception to that, utilizing a voucher process, whether that be using a card or providing a voucher to get a produce box. This report is specific to data collected in 22 and 23. Not all grantees submitted data, but this was a pilot which provided lessons and key takeaways for us. We were able to conduct formative interviews with grantees doing the capacity building track, and also who were operating programming, which was great. The first step to evolve and adapt for future dissemination of information and data. So this is our very first report, and we hope to really build on that. And then also we did have some carryover to some grantees in 2024, but that data is not included in this particular evaluation report. So these were the two funding tracks that organizations could have applied for with the RFP. We had two grantees that were doing a planning and capacity building grant. And so this could have been a number of things. It could have been they were starting a brand new program, or maybe they already had a program, but there were some staff needs or infrastructure needs, for example, improvements to teaching kitchens, or something that is in connection to their produce prescription program. And then we had 9 who were doing implementation projects. Again, this was something where they just maybe began a program and it was their very first cohort, or it was a continuation of bringing some innovation to their actual intervention, maybe some new partnerships, and evolving their actual produce prescription program. These were the grantees that received funding, and we have them highlighted under the sectors that they represent. So we had regional health systems that represented. We had a couple of federally qualified health centers. We had a couple local public health departments, and then we also had some community-based organizations, including Purdue Extension, which is a university land grant organization. And before I pass it over to Danielle, I wanted to briefly just share the process for data collection during this particular grant cycle. So for the implementation track, what happened there was when a cohort started, there was a registration, consent, and a pre-survey process through REDCap. And then at the conclusion of a cohort, there was a post-survey collection from the grantees. Grantees were provided links to REDCap to be completed for each participant that went through the program. And then there were also quarterly reports submitted to IDOH. And then on the planning and capacity track, there were quarterly progress reports that were submitted to IDOH. And then later on, when I onboarded, I updated the report submission through REDCap, but it was very similar. It was sort of some narrative reporting of, what are some successes, what are some challenges, what are some needs. That was typically what happened within that particular track. And then lastly, with a new pilot rollout, there's always limitations and lessons learned. These are, a few that we took note of. Many of these, though, have been addressed when I took on the Food as Medicine Director position. I had inherited these grantees, so, I worked hard on building those relationships and connecting with the grantees, and really worked on streamlining efforts to make it easier for grantees to submit reporting and also, have a contact person to reach out to. We're even, as far as evaluation goes, we're now even more advanced with hiring Jenny Durica, and she's our Food as Medicine data manager, to be able to really, spearhead that particular component of our work, because it is a heavy lift and it takes a lot of work to really be consistent when it comes to data collection and doing these types of reports. This quote here in the box, this is something that we put into the report. So future Produce RX projects, especially those in smaller communities, will likely benefit from additional technical assistance to support project management, data collection, and reporting. And so we want to continue to build off what we've learned from this report, and bring some ease and continue to collaborate together as we see these programs expand and scale and really, reach more Hoosiers across the state. All right, so I'm going to go ahead and pass it over to Danielle now to share about the methodology results and key findings.
Hi, everyone. Can you hear me okay? All right, good. I'm Danielle Savinsky, and I am part of the evaluation team at Limelight Analytics. And we worked with Michelle to conduct the evaluation for the pilot programs for produce prescription. All right, so first I want to give an overview of our methodology for the evaluation. So first of all, we were able to conduct a summative evaluation where we really looked at program outcomes. So how did participants benefit, or how did the program impact them? And so we were able to look at a couple different data elements. First, we analyzed the pre and post participant surveys that Michelle mentioned earlier. Those surveys were developed by IDOH, and then grantees administered them to participants both before and after they participated in the program. Participants could opt out of the survey, and it no way impacted their ability to participate in the program. Grantees also collected biometric data, and most commonly, grantees were able to collect height and weight, which allowed us to calculate BMI, and also A1C levels. So those are the biometric indicators that we really focused on for the evaluation. We also were able to conduct a formative evaluation where we really looked at program implementation. We wanted to learn from grantees the barriers, the facilitators, and what supports they might need in the future in order to continue their program. So we did this by reviewing a variety of programmatic data, including quarterly and final reports from grantees. And then we were able to conduct 6 interviews with grantees from those grantees that were still involved with the grant when we did the evaluation. All right, so let's focus on those program outcomes. So again, we wanted to look at participant level outcomes that allowed us to identify how the program impacted them, but also look at the characteristics of those participants who were engaged with the program. So you'll see that we were able to collect and analyze data for 7 of the grantees, 6 of which were able to provide us those pre and post survey results, and then 6 were able to provide those biometric indicators. Now you'll see that most of the grantees were able to provide, 20 or less data points for each of the indicators listed. However, I do want to point out that that last row there for Read Health, they had a majority of participants that were represented in our sample. So keep that in mind as we're reviewing the results, that the results from their program heavily drove the overall outcome results for all grantees combined. All right, so daily fruit consumption. So on the pre and post survey, participants were asked about the number of servings of fruit that they eat per day. So you'll see the 1 cup or less category decreased from 61% to 33% from pre to post. And then all of those higher categories, the 1 to 2 cups, the 2 to 3 cups, and the 3 cups or more, increased from pre to post. All of those changes, including the decrease for 1 cup and then the increases in the higher categories, were all statistically significant, suggesting that these trends were related to increased fruit consumption for those participants who were engaged in the program. We also saw similar trends for daily vegetable consumption. You'll see that we did have that decrease for 1 cup or less from pre to post. That was statistically significant. We did see a slight change from for the 1 to 2 cups category, but then you'll see that we had increases for those larger categories again. So increases for 2 to 3 cups and 3 cups or more pre to post. And again, those were statistically significant. So it is suggesting that these trends for participants that were engaged in the program, they were likely to consume more vegetables at the end of the program compared to the beginning. We also asked participants a variety of questions about other behaviors related to fruit and vegetables. And so you'll see that after completing the program, over 2/3 of participants reported that they have increased the amount of vegetables that they eat, enjoy, cook, and buy. And then you'll see, of course, strongly agree was most commonly reported for each of those indicators, suggesting that involvement in the program, participants were really seeing that they were increasing those 4 behaviors at the end of the program compared to the beginning. We also asked on the survey a couple of different demographic indicators, including if they were participating in SNAP, what their household size was, but we also looked at food insecurity. And on the survey, there were the 3 questions that were based on USDA's U.S. Household Food Security Survey. So if participants responded often or sometimes to at least one of those questions, they were considered food insecure. So you'll see that we had a 22% decrease from pre to post for participants who were reporting that they were food insecure, suggesting that participation in the program had a positive effect on food security for participants who were engaged. So for body mass index, we were able to review data for 363 participants. The average overall baseline BMI was 35.4 with a follow-up of 34.8. And that change of 0.6 was statistically significant from pre to post. We also saw that 61% of participants improved their BMI. Now, I do want to draw our attention to the average time between baseline and follow-up. So for all participants, it was around 285 days that they had to show changes from pre to post. However, this varied greatly from grantee to grantee based on their program model. So some grantees had a 4-month program, some had a 6 month, some had a year. And so I do want to draw that attention that even though the average was 285, some grantees had more or less time to show those changes. Though we didn't have any statistically significant changes in weight categories, we did see a slight increase in those that were at a healthy weight, and then a slight decrease for those that were in the obese category. For A1C, we were able to look at A1C levels for 340 participants. The average baseline A1C level was 7.5, the follow-up was 7.2, and again, that change of 0.3 was statistically significant. We saw that 59% of participants improved their A1C range, and again, just that average time between baseline and follow-up was 313 days, but again, I just want to note that that did vary greatly between grantees. We did see some statistically significant changes in the A1C ranges. So we had a 4% increase in those that were in the normal range, and then we had a 7% decrease in those that were in the diabetes range. So next I'm going to shift gears and I'm going to talk a little bit about our program implementation evaluation. We were able to conduct interviews with 6 grantees who were still involved with the program at the time of the evaluation. So I'm first going to talk a little bit about just the information that we collected about what their program looked like. And then at the end, I'll share some key findings that we found broadly across all grantees that we were able to interview. So first, I want to talk about the produce distribution method. So as Michelle mentioned, everyone had to use a voucher, but the way in which they used the voucher and then they were redeemed differed between grantees. So we had 3 grantees that utilized an electronic card or paper voucher system that allowed participants to redeem the voucher for fresh fruits and vegetables either at a grocery store or at a farmer's market. You'll see that the duration and the frequency varied between the grantees, and also the amount of the voucher also varied between the grantees. You also see that we had 1 grantee that solely had the vouchers redeemed at a farmer's market. We had 1 grantee that solely had vouchers where they used an electronic card for grocery stores. And then we had 1 grantee that was able to utilize both of those methods. The other way in which the vouchers were redeemed was through vouchers for food boxes. So participants received a voucher and then they were able to have a box that was already packaged with fresh fruits and vegetables that they got on a weekly basis. You'll see again the duration varied between the grantees that we were able to speak to. However, the value of the boxes was pretty consistent. We also had 2 grantees that were able to source some of the fruits and vegetables that were in the boxes locally, which means that they were able to procure them either through a community garden or a local farmer. We also looked at the way in which grantees were able to deliver nutrition education. It was a part of the grant. However, there wasn't a standardized nutrition curriculum or methodology that grantees had to use. So we thought it was important to see what they were doing in order to provide that nutrition education to the participants of the program. So you'll see that the duration and the frequency vary greatly between all of the grantees. However, we did hear that a lot of grantees really focused on those first few months to provide the nutrition education, and then it tended to taper off the longer the program went. We also found that grantees were able to offer a hybrid version of both in-person or virtual lessons. And then also we found that 4 were able to do some cooking demos, 2 were able to do some taste testing, and then 4 grantees were actually able to do some individual coaching where they met one-on-one with participants and provided the nutrition education that way. All right, so I'm going to go through our key findings here. I'm going to go through each of these in a lot of detail because I want to provide some additional information on what we learned specifically from the grantees that we were able to interview. So we did find that the produce prescription program administrators were often in the clinical field. So they were nurses or registered dietitians or other patient support healthcare professionals that were working one-on-one with patients. We found that this was really helpful for recruitment and retainment. Grantees had mentioned that because they had a relationship with these clients, it was easy to convince them to actually sign up for the program and keep participating. However, because the program administrators often had other clinical duties, it was difficult for them to do some of the grant management, including data collection and budgets and things like that. So moving forward, it might be helpful to have a clinical person who is really in charge of recruiting, engaging clients, and even providing that nutrition education, and then some additional support to do some of that grant administration work that was necessary. Though grantees were not required actually to collect data on retention. So we don't necessarily have hard and fast data of the number of participants who started the program and ended the program, although we did have one grantee that did have that data. We did ask grantees how they felt that their retention rates were, and they thought that they were high, and that there were high levels of engagement and retention in the program. So it is really important to look at retention, perhaps maybe in a more standardized way moving forward, just so that you can see if there's a certain time period where participants might be dropping off, or if they're necessarily not, maybe they're not collecting their boxes or they're not redeeming their vouchers, just so that you can identify ways that you may need to improve your program in the future. We also did not necessarily look at characteristics of grantees or of participants either, but it might be important to look at which characteristics of our participants are more likely to complete the program more than others. But again, we did hear that retention and engagement was relatively high among all of the grantees that we spoke with. So we did review that there were several different nutrition education models that were used by the pilot projects. Again, there wasn't a standardized requirement that grantees use a certain curriculum, although we did hear that most grantees were using some sort of evidence-based curriculum or modeled after that. Because the pilot program because the produce prescription program is somewhat short in length, so participants will only be receiving their vouchers for 6 months or a year, the nutrition education aspect is really important if we want to see them continue to engage in those positive behaviors even after the program has ended. And so we didn't necessarily get to see which nutrition education model was necessarily more effective than others, but it might be helpful to standardize that approach moving forward so we can see which nutrition model might be best for this type of program. Again, we saw that there were two primary models for produce distribution in the pilot programs. These came, each of the models came with their own barriers and facilitators. So with the electronic card or the vouchers redeemed at grocery stores, we heard from grantees that the initial setup of this process was a bit labor intensive. So securing the cards, making sure that the process was set in order for them to be redeemed at grocery stores, getting participants the cards, loading the cards on, that all kind of happened up front. So our grantees did report that though it was a lot of work up front, they were able to overcome those barriers, and then participants were able to utilize those benefits moving forward in order to procure their own fruits and vegetables at the groceries. On the box side, we did hear from grantees that it was labor intensive to secure the fresh fruits and vegetables, pack the boxes, and then get them distributed to participants. And when participants were not able to pick up their boxes, they also had to identify ways to get the boxes to the participants. We did find, though, that some grantees were able to partner with other organizations that already had this type of model in place, where they were used to packing things and then delivering them or having them available to participants. So I think that was a really important lesson learned to initiate partners that might be able to help in this process. But then again, the facilitators were that the participants were able to have those fresh fruits and vegetables on a weekly basis, and they were already packed and then available for them to use when they got home. And then lastly, again, it was not required that grantees actually collect demographics or characteristics on those that participated in the program, but we did hear from grantees that women were most likely to participate in the produce prescription programs. Now, this isn't because they were more likely to be referred. It was more likely that women were actually likely to sign up to engage in the program. Now, we did hear that women are more likely to be the gatekeepers of our food and our menus and everything that we're eating at home. And so we heard that although might have been just the woman of the family that wasn't signed up for the program. Other family members or extended family members often also benefited from the program. And grantees even reported that whole families would show up for nutrition education. And so moving forward, it might be important first to identify ways that we can engage more men to sign up for the program, but also perhaps have some sort of family model, because we are seeing that families are really participating and enjoying the program together. And I'll turn it back to Michelle.
Great, thank you, Danielle. That was wonderful. This last section that we're going to cover is how the report provided some really great insight on how we can strengthen produce prescription programs in Indiana. And so after analyzing the data and doing the key interviews, we took a lot away from that that can be done to really strengthen programming. And so here's a list that, and there's more that is included in the actual report, but one, really creating consistent implementation for produce prescription programs across Indiana. And I'll go into a little bit more details of that on the next slide. Developing data collection strategies to encourage and support evaluation of produce prescription programs. So what are some of those shared metrics? How can we collectively, get the same information, either that be more advanced technology or through EMR systems, or even through, the Indiana Health Exchange or Regan Street. Like there's opportunities that are being looked at and worked on right now. So I'll be able to go into a little bit more details again on that in a slide coming up. IDOH to develop tracking tools and ensure adequate staff capacity that allows for monitoring implementation progress among programs, particularly funded by IDOH. Develop resources and create awareness of produce prescription programs among local health departments who participate in the Health First Indiana. And really getting those local health departments engaged. Maybe they're not necessarily the ones operating the program, but they're engaging in their communities and with their healthcare partners and systems and food providers to potentially, really create a comprehensive program. Healthcare systems serve as a model for reaching large groups of individuals benefiting from produce prescription programs. And so it's really going to be important that as you consider programming, if you are not a healthcare system, that you're making sure you're embedding, as much of the programming into the healthcare system as possible and having that partnership. And then also develop sustainable funding sources for produce prescription programs, which is what we are always working on. I think not even at IDOH, but all of us as implementers across the state are constantly looking for, what is that next funding stream going to be to continue programming? And so with that first bullet point, as we see more research and programs evolve, evidence-based practices and sustainable funding opportunities, standardization of produce prescription programs may be very important. This includes having further discussions as program implementers about what are the program designs and what is the duration that is most effective. What is the dosage of produce, either financially through a card or voucher or a produce box, that is making an impact on health outcomes? And what metrics do we want to make sure we are collecting and measuring and reporting on? And also, as I mentioned before, how are we reporting on that? For example, our EMR systems. I think we're very hopeful in the next phase that we could really start having these conversations and maybe create some alignment across the state when it comes to program design and implementation itself. When we talk about evaluation, these are key topic areas that will be important to build on and learn on from peers who are already integrating their evaluation into EMR systems or EHR systems, and also collecting the same metrics. This is, potentially creating a working group around this and what it may look like. and really identifying what everybody's roles are. And additionally for us at IDOH, like what is our role on what we can actually collect and continue to report on, so that we're sharing it with our leadership and also our policymakers, to really, continue to move this work forward and get the support that it needs, and even, that financial stability. So with this, I'm just taking away this promising future for produce prescription programs. I'm really excited to see them advance in Indiana. And we all can help become, as we become subject matter experts in operating produce prescription programs, and really continuing to bring awareness to the impact and importance of these programs to treating, to managing, and preventing chronic disease. Um, I think having these further conversations down the road about, how can we get even specific reports from programs that are operating across the state that we can embed into our communications and bring more awareness to your program as well would be really fantastic. Um, and we want to continue to contribute to the research. There's a lot of national research being done that has proven effectiveness of these programs, and we want to be able to contribute to that. So the more data that we can get and we can disseminate out, the better support that we're going to see for the future of it. Hoosiers going through these programs are appreciative, and they're very from benefiting from these programs. We constantly hear very positive feedback. And even my time at the Marion County Public Health Department and as a program implementer, we heard that all the time, and doing focus groups and really hearing the impact that it makes. And as Danielle mentioned, not just for themselves, but also for their entire household. We want to continue to build capacity to provide support and technical assistance. And then also, as I already mentioned, more awareness to food as medicine overall and specific interventions such as produce prescriptions, and then continuing to see the federal and statewide advocacy happening. And, so if that is something that you can or your organization can do, how can you be a part of that piece of the puzzle? And then lastly, second to last, we want to continue to build and revitalize the network and the produce prescription community of practice. We really want that to be a place for implementers to be able to get support, network with each other. So, please share your ideas on how we can do that. We will be hiring a new food as medicine director. But as I mentioned in the beginning, I am still here and available to help and assist, where I can. And also our great leader, Shalise, leading the Indiana Nutrition Incentive Network there. Feel free to reach out to her on any of those questions. And then lastly, many of you may already be aware, maybe all of you, but we want to bring awareness and a reminder to the Food as Medicine Landscape Scan Survey that is currently live. Lindley is on the call as well, who really spearheaded getting this going. And, our goal is to be able to collect as much information around food as medicine interventions, including produce prescriptions, and being able to take that information and analyze it and then, disseminate those results out as well. I think being able to identify everything that's happening across our state and seeing what are some of the themes and what are, who are the different stakeholders that are involved are going to be super helpful for us to move things forward. All of this will be sent to you, and along with the report. I'm going to go ahead and actually stop sharing my screen here, and I'm going to pull over the report. And share there. So this is the cover of our produce prescription pilot program evaluation report. And it is 31 pages. And we are hopeful that it'll be very informative and helpful to you all. We are obviously, open to thoughts and ideas and any feedback as we move forward with creating, more reports and building off of this one. And we really appreciate you all being a part of this, and also being here today to have us provide this information and disseminate out our very first report on produce prescriptions. And I guess at this point, we'll just go ahead and open it up for any questions, clarifications, comments that we can provide. Or any discussions anybody wants to start on or talk about? Great, thank you, Christina.
Hey, Michelle, it's Jamie with the Vanderburgh County Health Department. How are you?
I'm good, how are you?
I'm doing well. I was just wondering if you have heard of any word of restoration of grant funding moving forward.
Yeah, so that's a great question. Right now, at least at the state level, we are at a pretty we're not seeing any like federal money coming in. Right, with the SNAP Ed ending, it's really put a damper on a lot of things. With me in my new position here at the foundation, one of the goals is to really seek more private dollars where we can, and applying for some of those private grants that traditionally the state agency can't apply for, but the Healthy Hoosier Foundation can. And so we're going to continue to leverage where we can in that space. Um, we we have submitted a proposal, not so much asking for money, but for the Division of Nutrition and Physical Activity to actually create a program, like a food as medicine program in statute, so that we have that within the budget line, but it may not have any money at first. So then when the budget year does come, we can then propose funding to be able to secure for programs like produce prescription. So that's, yeah, I mean, we have, and Chris here with AHA, we've got other stakeholders that are really helping us in that space. And so, and I know that might not be the answer, Jamie, you wanted to hear. But at a federal level, besides GusNIP, we haven't seen any funding. And also with GusNIP, I know with nutrition incentives, there was no 25 RFP. I'm not quite sure if PPR is the same. And I know we do have a couple GusNIP PPR funded projects in Indiana. But again, those also may be ending soon as well. So we have to continue to work towards this.
It is the same for PPR. There's no
Is it?
25. Yes.
Okay.
Thank you, Michelle.
Yeah. But feel free to, especially in my new role with this foundation, if there's anything that you do see that would make sense, that we as a foundation could actually apply for, feel free to send it my way as well. And, again, I know there was a major cut with Health First Indiana for the local health departments. But I think it's important as we continue to work on diet-related chronic disease and an obesity plan for the state and aligning with executive orders that we have. It will be critical for our local health departments to continue to advocate for using some of those dollars towards interventions like produce prescriptions that we know are making an impact and are effective. Anything else? Well, there is more to come. Like I said, this is just the beginning. As you know, this work is complex. It can be hard and but also very rewarding at the same time. So I just want to say thank you to everybody for all that you do in this space. Um, and that we are here to help and support in any way that we can. Shalice, did you want to end with anything?
Oh, yeah, I just want to let everyone know that our next full meeting will be on December 16th. We will talk about our year, how our success is, our challenges, and then we'll plan for 2026. So bring your ideas and your questions, and we'll discuss. And we will be sending out this recording so that you can share it with your networks as well.
And I just want to quickly say thank you again to Danielle for being a part of the presentation today and all of the work that Limelight put into this report.
Yep. Thanks, Daniel. All right,
Okay.
everyone. Thank you and have a great rest of your day.
See you later.
Thank you. Bye.